very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a presentation on management of muscle-invasive bladder cancer. This will be presented by our resident, Dr. Sarvesh, and would be moderated by our faculty, Dr. Manoj, Bamania. So I would request Sarvesh to go ahead, please. Sarvesh, share your presentation.
Share.
Full screen, please. Yes, go ahead, please.
Good morning, sir. My presentation is on management of muscle-invasive bladder cancer. Natural history: majority of bladder cancer are patient with bladder cancer present with de novo muscle-invasive disease as its first manifestation. Rest 15 to 20% progress from non-muscle invasive after treatment with intravesical therapy. MIBC must be considered as systemic disease. Therapeutic strategies designed to target locoregional disease, bladder and pelvic lymph node, and occult visceral metastasis disease according to pathological risk factor. Histology: most common cell type is transitional cell carcinoma. Squamous cell carcinoma predominates where bilharziasis is endemic. In setting of chronic indwelling catheter and recurrent infection, squamous cell carcinoma is most common histology. Adenocarcinoma of bladder is uncommon but occur in bladder base, trigone area. Patient with dystrophy are at the increased risk of carcinoma. Surgical treatment of cervical adenocarcinoma is partial cystectomy. Small cell neuroendocrine cancer is a rare variant, easily distinguished by the ISC expressing synaptophysin and chromogranin. Treatment requires neoadjuvant chemotherapy, cisplatin and etoposide followed by radical cystectomy or radiation therapy. May also be associated with paraneoplastic syndrome. Micropapillary variant is an aggressive variant, trends towards high grade and high stage carcinoma, frequently associated with lymphovascular invasion. Radical cystectomy is a treatment of choice because it typically don't respond to chemotherapy directed to TCC. TNM staging of bladder cancer. TX primary tumor cannot be assessed. T0 no evidence of primary tumor. TA non-invasive papillary carcinoma. T in situ carcinoma in situ flat tumor. T1 tumor invades the subepithelial connective tissue. T2 further divides in T2A, T2B. Pathological T2A is tumor invade the superficial muscularis propria, is the inner half. T2B tumor invade the deep muscular propria, is the outer half. T3 further divided into T3A, T3B. T3A is microscopically, T3B is microscopically extravesical mass. T4 further divided into T4A, T4B. T4 is tumor invade the prostatic stroma, is uterus and vagina. T4B invades the pelvic wall, abdominal wall. Regional lymph node. Annex lymph node cannot be assessed and no lymph node metastasis, and one single regional lymph node metastasis in the true pelvis is hypogastric, outflatal, sternal iliac and presacral lymph node. And two, multiple regional lymph node metastasis in true pelvic lymph node. And three, lymph node metastasis to the common iliac lymph node. Distance metastasis M0, no distance metastasis M1, distance metastasis. Up to 40% of patients initially diagnosed with T1 who undergoes cystectomy have pathological T2 disease. More than 9 lymph nodes have to be investigated to reflect the pathological and not appropriately. Diagnostic evaluation. Painless hematuria is the most common presenting complaint. Bimanual examination should be carried out before and after TURBT. Discrepancy between bimanual examination and pathological T stage after cystectomy. 11% clinical overstaging and 30% understaging. Bimanual examination. Finding described originally by Marshall in 1952. T2A non-palpable, T2B in duration but no three-dimensional mass. T3 is a three-dimensional mass that is mobile. T4A invading adjacent structures such as the prostate, vagina, or rectum. T4B fixed to pelvic side wall and not mobile. TUR of invasive bladder tumor. A small tumor less than 1 centimeter can be resected en bloc. Large tumor need to be resected separately in parts which include exophytic part of tumor, underlying bladder wall with retrosal muscle, the edge of resection area. Status of bladder neck in female and prostatic urethra in male serve as a basic for planning appropriate management of urethra and urinary diversion. In women, bladder neck biopsies are an accurate surrogate for urethral biopsy. Involvement of prostatic urethra and ducts in men seems to be higher if tumor is located on trigone or bladder neck, presence of carcinoma in situ, and multiple tumor. Staging of prostatic urethra. Using a resectoscope, take a full loop from the mid prostate or bladder neck in the short prostate to the mid to distal verumentonum and 5 and 7 o'clock adjacent to the verumentonum. This is the site where the highest concentration of prostatic ducts and where CIS is most likely to be found. Full thickness chips allowed pathologists to see interface between urethral mucosa, prostatic duct, and stroma. Most accurate means of staging prostatic urethra. Negative prostatic urethra biopsy is associated with a negative apical urethral margin and obviate the need for intraoperative Folgen section. If indicated in male, urethral Folgen section has to perform on the just below the verumentonum bladder neck and on the inferior limits of bladder neck for female. Concomitant prostate cancer. Prostate cancer is found in 25 to 46% of patients undergoing cystectomy for bladder cancer. The impact on survival is unknown. Staging of MIBC. Determine the effect of local tumor on upper tract and presence of any synchronous urothelial cancer of ureter, renal pelvis, or urethra. Extent of local tumor invasion. Tumor is spread to the lymph node. Other distant organ like as the liver, lung, bone, peritoneum, pleura, and adrenal glands. Laboratory testing at a minimum should include blood urea nitrogen, creatinine, electrolyte, CBC, LFT. CT. CT has replaced intravenous ureterogram for upper tract imaging. CT is having an added benefit of imaging of pelvis, iliac lymph node, and rectoperitoneal lymph node as well as liver. Both CT and MRI may be used for local invasion. Unable to accurately diagnose microscopic invasion of perivesical fat T2 versus T3A. Principal aim of CT and MRI is therefore to detect T3B disease or higher. Pelvic node more than 8 mm and abdominal nodes more than 10 mm in maximum short axis diameter should be regarded as a pathologically enlarged. PET-CT. HSCT should be obtained routinely in the patient with muscle invasive disease or N+ disease in whom the risk of visceral metastasis is greatest. PET-CT has no defined role for routine staging of nodal or visceral metastasis in invasive bladder cancer. Can be helpful in identifying nodal or visceral metastasis disease where these findings will determine the use of chemotherapy or surgery. MRI. MRI useful for patient with allergy to iodinated contrast or in patient with an equivocal bone scan. Dynamic contrast enhanced MRI may be helped to differentiate bladder tumor from surrounding tissue or post-biopsy reaction because enhancement of the tumor occurs earlier than that of the normal bladder wall. Due to neovascularization, ferromagnetic nanoparticles are taken up by the macrophages and dark area represented by the metastatic deposit can be detected with the foci as small as 3 mm. Need further study and validation. Bone scan. A bone scan and additional brain imaging are not routinely indicated unless the patient has specific symptoms or signs to suggest bone or brain metastasis. Bone scan is patient with elevated alkaline phosphate or new onset bone pain. Indication of cystectomy in T1. T1 disease include the size greater than the 3 cm, micropapillary histology, and lymphovascular invasion. According to EUA and MIBC guideline, it is responsible to propose immediate radical cystectomy to patients with non-invasive muscle tumor who are at the higher risk of progression. T1 tumor, grade 3 high grade of tumor, CIS, multiple and recurrent and large more than 3 cm, TA, grade 1, grade 2 tumor, all conditions must be presented with in this point. BCG refractory tumors. Radical cystectomy is also strongly recommended in the patient with BCG refractory tumor defined in the NMIBC guideline as muscle invasive tumor is detected during the follow-up. If higher grade non-muscle invasive papillary tumor is presented at the 3-month, if CIS without concomitant papillary tumor is presented at both 3 and 6 months, higher grade recurrence after BCG despite of initial response. Neoadjuvant chemotherapy. The standard treatment for patient with muscle invasive bladder cancer is radical cystectomy. However, this is a gold standard, only provides 5-year survival is about 50%. To improve these unsatisfactory results, neoadjuvant chemotherapy has been used since 1980. Rationale intent to treat micrometastasis. Neoadjuvant cisplatin containing combination chemotherapy improves the overall survival 5 to 8% at 5 years. Advantage of NSE. Advantage. Chemo delivered at the earliest when burden of micrometastasis is expected to be low. Potential reflection of in vivo during drug chemosensitivity. Probability of chemo and patient compliance are expected to be better pre-cystectomy. Patient might respond to NSE and reveal a favorable pathological status determined mainly by achieving pathological T0 and may downstage the tumor. Don't seem to affect outcome of surgical morbidity. Disadvantage of NSE. Disadvantage. Delayed cystectomy might compromise the outcome in patient not sensitive to the chemotherapy. Over treatment of non-responder and patient in non-targeted population is a possible negative consequences. NSE approaches has not been widely accepted. Many urologists believe that potential 5% advantage in overall survival is not greater enough to justify giving toxic chemo to all patients before surgery. NSE should always be cisplatin-based combination therapy. Conclusion of NSE. NSE intended for patients with operable T2 to T4A MIBC. Available data support use of MVEC and or CMV as a neoadjuvant chemotherapy. These regimen less frequently used today because of gemcitabine and cisplatin has been widely used for metastatic disease. In average, this patient with clinical T2 cancer benefit of adding chemo to local therapy is best modest. A more substantial benefit for patient with clinically T3B disease. Pre-op radiotherapy. No data exists to support that pre-operative radiotherapy is for operable MIBC increased survival. Timing of cystectomy. A delay of more than 12 weeks have negative impact on outcome and should be avoided. Indication. Traditionally, radical cystectomy recommended for MIBC T2 to T4A and not to NX M0. Extensively papillary disease that cannot be controlled with TRBT and intravesical therapy alone. In non-responder to conservative therapy, recurrence after bladder sparing treatment, non-urothelial carcinoma respond poorly to chemo and RT, purely palliative like as fistula formation for pain and recurrent visible hematuria, microhematuria. In standard radical cystectomy, we remove the in men, we removal of bladder, distal ureters, regional lymph node, prostate, and seminal vesicles. In women, removal of bladder, distal ureters, regional lymph node, entire urethra, and adjacent vagina and uterus. A formal bowel preparation may not be necessary. Bowel recovery time has been reduced by the use of early mobilization, early oralization, and gastrointestinal stimulation with metoclopramide and chewing gum. Managing of female urethra. In sexually active women, vaginal preservation and reconstruction must be discussed with and planned pre-operatively. Cancer at bladder, neck, or urethra or at T4 tumor involving the anterior vagina is a contraindication to urethral preservation and creation of an orthotopic neobladder. Posterior extent of pelvic and iliac lymph node dissection. Lymph node metastasis is found in 20 to 25% of patients who undergo radical cystectomy. It is the most important prognostic factor in these patients, predicting the significantly decreased disease-free survival and overall survival compared to patient without nodal metastasis. 7th edition of AJSAG studying notes that at least 12 nodes should be removed. Standard lymphodectomy. Standard lymphodectomy in bladder cancer involves the removal of nodal tissue primarily up to the common iliac bifurcation, ureters being in the medial border, lateral border are the genitofemoral nerves, Podily lacunar ligament, lymph node of blockade, and also include the internal iliac, presacral, obturator fossa, and iliac, external iliac lymph node is a true pelvic lymph node. Extended lymphadenectomy. Extended lymphadenectomy includes the all lymph node in the region of aortic bifurcation and common iliac vessels. Regional lymph node consists of all pelvic lymph node below the bifurcation of aorta. Mapping studies have found that ischemic lesion at the location above bifurcation of aorta without more distally located lymph node metastases are rare. Super extended can lead to the level of inferior mesenteric artery. When positive lymph node N1 metastasis in single node in true pelvic, orthotopic neobladder can still be considered, but not in N2 and N3 tumor. Grossly positive nodes and T4B disease. If recognized on preoperatively imaging and outside the true pelvis, CT guided biopsy is performed. If it is positive, chemotherapy is initiated followed by cystectomy. When adenopathy encountered at the time of cystectomy, frozen section is undertaken to confirm the presence of metastasis. Extended lymph node dissection and radical cystectomy are performed. Cystectomy is not performed when lymph node mets are unresectable because the bulk are proximal instead above the common iliac vessels. Evidence of extensive periurethral disease. Bladder is fixed to the pelvic side wall. Tumor is invading the rectosigmoid colon. Survival. Pathological tumor stage and nodal status are primarily variable, affecting the risk of progression and survival probability following by cystectomy. Lymphovascular invasion as an independent predictor of outcome. Positive surgical margin are having adverse impact on survival. Up to the 50% of patients with infiltrating disease develop METs and ultimately succumb to their disease. Prelude to the occult metastasis disease present at the time of initial diagnosis. After metastasis develop, some 70% have disease that is sensitive to chemotherapy. The suggestion is that systemic treatment in addition to radical cystectomy is required. Adjuvant chemotherapy. In patients with pathological T3 and T4 disease and N+M not disease, 5-year survival after radical cystectomy is only 25 to 35% at best. Radical cystectomy showed significant improvement of progression-free survival for immediate compared to the deferred treatment. However, no significant of overall benefit. Cisplatin-based chemotherapy result in long-term disease-free survival even in metastatic disease, mainly in patients with lymph node metastasis only and with a good performance status. Adjuvant cisplatin-based combination chemotherapy can be offered to the patient with pathological T3 and T4 or pathological N+ disease if no NSE has been given. Unresectable tumor. Palliative cystectomy for MIBC. Locally advanced tumor may be accompanied by the debilitating symptoms like as bleeding, pain, dysuria, and urinary obstruction. These are candidate for palliative treatment. Palliative cystectomy with unidiversion carries the greatest morbidity and should be considered for symptoms relief only if there are no other options. Bleeding and pain. Bleeding. Screen for coagulation disorder or review patient use of anticoagulation drugs. Transurethral laser coagulation. Intravesical rinsing of bladder with 1% silver nitrate or 1 to 2% alum can be effective. Can usually be done without any anesthesia. Vesical urethral reflex should be excluded. Radiation, another common strategy for control of bleeding and is also used for control of pain. Non-conservative option like as embolization of specific arteries in small pelvis with success rate as high as 90%. Bladder preservation and combination modality approaches. Radical turbidity for selection of candidate strict criteria are required and include initial occurrence of bladder cancer, no CIS, size less than or equal to 3 cm, stage T2, no palpable mass, not in the dome or higher posterior wall. Patient with T3B and T4 are not a candidate. Radical turbidity. All patients must undergo resection 3 months after radical turbidity. If tumor persists at this time, radical cystectomy is considered. Advantages. At least a small portion of patients preserve their native bladder and optimum quality of life. Disadvantage. Absence of pathological staging of pelvic and iliac lymph node and requirement for lifelong surveillance because of up to 25% ultimately requires cystectomy. Radiotherapy. Radiotherapy alone not recommended as primary therapy for localized bladder cancer. External beam radiotherapy alone should only be considered as a therapeutic option when patient is unfit for cystectomy or multimodality bladder preservation approach. Trimodality therapy and multimodality therapy, it permits the bladder preservation by sensitizing tumor to radiotherapy and perhaps also treating occult metastasis. Majority have used cisplatin as radiosensitizing agent, aim to preserve bladder and quality of life. It includes maximum turbidity of bladder tumor, external beam radiotherapy with radiosensitizing chemo given concurrently, and a careful urological based surveillance program with a prompt cystectomy for persistent or recurrent invasive tumor. Carefully selected patient with small T2 tumor who undergo complete turbidity have no evidence of urethral obstruction and have complete response to chemoradiation are most suitable candidate. Factor associated with maintaining bladder includes clinical stage, tumor size less than 3 to 5 centimeter, absence of hydronephrosis, absence of palpable mass, and unifocal disease. Multimodal treatment with multimodal treatment, 5 years cancer specific survival and overall survival rates of 50 to 80% and from 36 to 74% were achieved respectively. Salvage cystectomy rates are 10 to 30%. Majority of recurrence post MMT are non-invasive and can be managed conservatively. MMT may be considered a reasonable treatment option in well-selected patients as compared to the radical cystectomy. It should also be considered in all patients where surgery is contraindicated.
Thank you, Sarvesh. Again, requesting all my residents and faculty and all those who might have joined us to give your suggestions, any ideas, or any queries regarding this presentation. So, just a brief summary about muscle invasive bladder cancer. We all know bladder cancer, again, is a very important topic for urology trainees. As we know, this is the 6th most common cancer in men, right? And 25% of the cancers would be muscle invasive disease. So when we talk about the various risk factors of bladder cancer, very important to counsel the patient to stop smoking. Smoking is the biggest risk factor in bladder cancer. Then there are some occupational hazards, aromatic amines, and there is a drug which is called pioglitazone, which is used for diabetes, where if the patient has a history of bladder cancer, there is an increased chance of recurrence that is seen. So don't use pioglitazone if the patient has a bladder cancer. When we talk about the diagnosis, definitely after doing a study, imaging study, and the patient will usually present with hematuria and sometimes with low urinary tract symptoms also. So go ahead and do a ultrasound. If you find a bladder mass, then if the patient, it presumably looks like a muscle invasive, go ahead and do a CT or a MRI imaging. MRI imaging for staging of the bladder tumor, for knowing the local advancement of the bladder tumor, probably scores a little higher above CT scan. We also know that now we have various studies on Virate scoring also, where we can know the local advancement of the bladder tumor. Urine cytology, again, should be done in these patients. And when we come to the treatment protocol, we all know radical cystectomy probably is the best treatment of choice in patients who are actually fit for surgery. But the other options, again, include radical radiotherapy and even chemotherapy. So chemotherapy or chemoradiation or radical radiotherapy or radical cystectomy. Other options include doing sometimes a partial cystectomy or a diverticulectomy when the tumor lies only in the diverticulum, particularly tumors like urethral adenocarcinoma are present only at the dome, or sometimes endometrioma of the bladder, which presents at the dome, we can do a partial cystectomy, but we should have at least a 2 centimeter margin around the tumor before we do a partial cystectomy. So the bladder should have adequate capacity. Another option that he said was about radical TURBT. So all these are bladder preserving protocols, where if the patient is not willing for surgery and very selected patients, we can go ahead and do a bladder preserving protocol in the form of partial cystectomy, diverticulectomy, or doing a trimodal therapy with radical TURBT followed by radiotherapy and sometimes by chemotherapy. We all know that neoadjuvant therapy in muscle invasive bladder tumor has proved to be better because it has shown a survival improvement of around 45%. So if the 5-year survival rate of muscle invasive bladder tumor is around 45%, then after neoadjuvant therapy, if you do a radical, it is around 50%. So giving neoadjuvant chemotherapy, in particularly patients who can't tolerate chemotherapy, is a better option than doing only radical cystectomy. But again, there are disadvantages that if you go ahead and do chemotherapy, patient doesn't have a full response, and in the meantime, the cancer can advance. So that is one of the limitations of chemotherapy. So it's important to find out which patients would respond to chemotherapy. So there are many studies which have come out with molecular markers where these markers will tell you which patients will respond to chemotherapy and which patients would not. So a better option in the future probably would be to find out these patients who would respond to chemotherapy, give them neoadjuvant, and then follow them by radical cystectomy. Then we also know the radical cystectomy could be done in locally advanced patients also when it is T3AB or even 4A. So all these patients probably would require, as he said, a multimodal therapy or trimodal therapy, including radiotherapy, radical cystectomy, and chemotherapy. Sometimes even a 4B stage disease, we can give a chemotherapy 6 cycles and see the response, and then do a salvage cystectomy. So these are the various treatment options. Adjuvant chemotherapy, if the patient has not been given neoadjuvant chemotherapy, then adjuvant chemotherapy is again one of the options, particularly patients where we find the lymph nodes positive, or it is better to give a neoadjuvant chemotherapy. Lymph node metastasis, because it has been found that almost 25% of these patients will have micrometastasis in the lymph nodes, even if they are not found on imaging. Doing a lymph node dissection is part of radical cystectomy, right? So nowadays we have extended template lymph node dissection where we remove the presacral lymph nodes plus the lymph nodes at the bifurcation of the aorta, right? So we need to do that extended lymph node dissection to have a slightly better outcome. So doing a lymph node dissection probably would be a better, extended would be a better option. Another option in these patients would be like those who do not respond to chemotherapy, or would be to add immunotherapy. The drugs, abilimab and etc., have been tried in various studies where we have seen that this immunotherapy might be a good option in the future. I think that's it. These were probably, this is how we probably would manage muscle invasive bladder cancer. If anybody has any query, residents, do you want to ask anything? Yes. Okay. Okay, very good question. If after giving neoadjuvant chemotherapy and doing a radical cystectomy, lymph nodes come to be positive. So again, if the lymph nodes are positive, then again, adjuvant chemotherapy would be an option giving. Again, because to complete the 4 cycles of chemotherapy, because it's almost a metastatic disease there. So that is another option. Yes. Anybody else? Even so another question that whether if there's a T1 disease, is there any indication of radical cystectomy? Yes, we discussed in the non-muscle invasive bladder cancer in the last class. What are the various options of non-muscle invasive bladder cancer being treated with radical cystectomy? So one of the option was extensive disease of the whole bladder, where we cannot resect the whole tumor. That is again one of the indications. We know other indications: BCG unresponsive, and then you have recurrence. If there is associated carcinoma in situ, again all these are various options in non-muscle invasive bladder cancer for radical cystectomy. Again, radical cystectomy, after that we do a urinary diversion. Then what kind of urinary diversion, that is again also debatable. Whether to do a conduit or to a catheterizable pouch or orthotopic neobladder. So there are various limitations, advantages, merits and demerits of all these. And you have to actually judge according to the various criteria, according to the surgeon's preference, it's his expertise, the patient preference, the associated comorbidity, whether these patients would be able to have a proper stoma care or not in the future. So all these factors would come into play when you decide about the urinary diversion. One word about the various ways by which we can do radical cystectomy. We all know we have been doing open radical cystectomy. Now laparoscopic radical cystectomy is becoming very common. Robotic radical cystectomy. It's not only we are doing an intracorporeal urinary neobladder formation also, and ileal conduit is also being formed. So again, the various studies have shown, particularly a trial called RAZOR trial, which compared robotic lap and open radical cystectomy, have showed almost equal results. So so I think still it remains the surgeon's preference to choose which technique to be chosen. Yes, anybody? Okay, so if there is no question, I don't think there is any message on the chat box also. If no, any of the faculty members who are online, if would like to add something, they are most welcome. Otherwise, I would request Dr. Manoj to kindly wrap up the session as the moderator of the session. Yes. Yes.
Thank you, sir. Thank you, Sarvesh, for good presentation. And thank you, sir, for valuable information. Good day.
So thanks, everybody. Have a good day.